Welcome to another episode of Reboot with Dr. Arasi Maran. I'm your host, Dr. Arasi Maran. I have a special treat for y'all today. I have a guest by name Dr. Andrea Pazella. She is the co-founder of Southern Urogynaecology at Columbia, South Carolina. She is here to talk about all things you can do just beyond taking medications for your postmenopausal health and especially sexual intimacy. So, we are going to hit a lot of taboo topics here. Be ready for it. Just don't get all offended or red in your cheeks when you hear different words being used. So, we are going to deep dive and really deep dive into different aspects of what happens to a woman's body and which invariably affects her mind after menopause. No further ado, Dr. Pezzella, thank you so much for being here. And to start off with, can you go ahead and introduce yourself and tell us how you landed with this practice right now?
Sure. Thank you, Dr. Moran. I really appreciate the opportunity to be on your podcast today. So I am a urogynecologist. I specialize in female urinary incontinence, pelvic floor problems. It is a subspecialty of obstetrics and gynecology and female urology. I have my own practice. I founded in 2010, Southern Urogynaecology here in Columbia, South Carolina. I have been working there and building a standalone practice on my own for the last 13 and a half years. I just hired a partner last year. It has been exciting. That's kind of a new thing for us, and it's been wonderful. She's been a wonderful addition because this practice in itself has grown so much. And so dealing with women in their, what I call their mature years, has been my focus and my passion to help women with their urinary and pelvic floor and female pelvic disorders.
I have to say, I have to commend you for taking this on because not many people focus on this. And usually, as you said, women in the mature age give up on all these problems. They don't even want to talk about it. They don't want to accept that they're having these issues. They live in silence, they live in pain. So I really commend you for taking this on and bringing this out. My previous podcast, I talked about postmenopausal health with Dr. Carolyn Myers. After that, so many of my office staff was like, where are these unicorn doctors? Where can we find them? Is there some? And she Googled the other doctor. She was from Texas. So she's like, is there anyone in South Carolina? I was like, you know what? I am going to find someone in South Carolina for people in South Carolina and to reach out. Now, is your practice just office based or do you also do telemedicine consults and things like that?
Yeah, so we have a majority of our patients come into the office because we do a comprehensive evaluation, a physical exam, and we do have some telehealth. When it was COVID, of course, we switched to telehealth. It was effective in so far as follow up with medications, but really, I think what we do in the intimacy of the problems that women have that come to us, we really feel like an evaluation with a physical exam is really important. Because we
Okay.
deal with so many of the pelvic floor issues, it's hard to have a telehealth visit unless it's strictly hormone replacement therapy.
Funny part of when you said pelvic floor issues, etc., we never know, even in medical school, I don't remember being educated about what happens to the pelvic floor after childbirth or what happens to all of our vaginal walls, etc., after we attain menopause. Can you kind of take us on what happens to our sexual health after menopause or even during the perimenopausal period?
So we tend to see the patients who women have gone through their reproductive years, they were going to see their OBGYN, and then there's this sort of 10, 15-year span where they don't see a OBGYN and they told they don't need a pelvic exam anymore or a pap smear. And so they come in for other problems, urinary issues, incontinence, pelvic prolapse, which is a drop of their organs after childbearing and other issues that may occur. And so we're seeing these patients and they have a lot of postmenopausal issues that are physiologic, chronic, that women don't speak about. it's very taboo. They're embarrassed. And so they come in and they tell their primary care doctors, and it's hard for them to navigate how to address these issues. So they come in and they'll have what we call the genital urinary symptoms of menopause. And that's somewhat of a new phrase. It's been out since 2014. And it's really the postmenopausal changes that occur from the depletion and lack of estrogen. So you can subcategorize it into three groups. There's genital, so your vulval vaginal issues. There's sexual, and then there's also urinary. So you have women that will have experiences of vaginal dryness, itching, burning, irritation, sexual discomfort, pain with intercourse, lack of lubrication, decreased libido or desire. And then you have your urinary issues. They may experience some form of incontinence, leaking when they cough, laugh, sneeze, jump, exercise. They can no longer jump on the trampoline anymore. And they're thinking that this is something that they can't fix. Or they have to rush to the bathroom all the time and they can't get to the bathroom and they find themselves leaking. And also chronic urinary tract infections. So these are all symptoms of issues that occur after menopause. And they can start occurring in the perimenopausal phase, but they can get 50% worse
Oh,
after
wow.
they've gone through menopause because there's no estrogen. So estrogen really supports that tissue. It supports the bladder. And so a lot of times women will come into my office and we just address those issues. And it's kind of miraculous if we can just get them started on a simple topical hormone replacement therapy, particularly if they're after like 60, say. And oftentimes it's a woman that, may have not realized she's had these symptoms and she's newly married and she
Mhm.
wants to be sexually active. And so simple treatment like that can really help tremendously with their urinary and vaginal vulvar symptoms of itching, burning, or irritation.
We talked about hormone replacement therapy. So, does hormone replacement, like the topical steroids, etc., does that cover all of this, or is this a separate additional therapy?
Right. So your hormones that are maybe systemic that you could add back in the early phases between 50 and 55 is what the general rule we recommend. And hormone replacement therapy is recommended because that can help the what we call vasomotor symptoms, the hot flashes, night sweats, moodiness. And that can really help impact, fatigue and a lot of probably our whole body systemically. But then there's those genital symptoms that may not get covered. They can have improvement with vaginal dryness, but if we're talking about women that come in that have not seen estrogen for 10 plus years, then you're at risk to start them on hormone replacement therapy because there is data that does show that if you haven't had a hormone replacement therapy over 10 years, the estrogen can actually, by adding it back systemically, can impact as you may know, the cardiovascular, the vessels. And if there is any kind of plaque formation, then that's where there can be some
Rupture of
cardiovascular
the plaque,
issues, and it can
yes.
rupture the plaque, change the endothelium of the vessel, and then there's your increased risk of heart disease and stroke. So for those women, adding it back locally does not get into it doesn't get absorbed into the bloodstream. So we're just dealing with the local effect. So adding back estrogen in a topical form can serve to help with those genital issues. And so a lot of times we'll add it back and they have significant improvement in that local area.
That's so strange. Something as simple as literally a cream is going to make such a big difference. And I think the key point here I want to make for any women or men who know women in their late 40s and late 50s, don't let them suffer in silence. Go ask them about the question. To go 10 years without estrogen is like, can you imagine a man going 10 years without testosterone? It never happens. And here we are, women just suffering in life, suffering quietly, but going without estrogen. And if the data really is that if you don't go without estrogen, when you add it back, it's going to actually increase your risk of heart attacks, then it's better to always constantly have this discussion with your providers so that you can get the right therapy you need. That's
Well,
pretty shocking.
hormone replacement therapy got a bad rap. I mean, the Women's Health Initiative, when it came out almost 20 years ago, and I remember I was just starting my practice, and it almost was like a relief to a lot of OBGYNs because they didn't feel like, oh, great, I don't have to have the conversation anymore about hormone replacement therapy and what's good for them. And it was really unfortunate and a shame that we just abolished everyone woman went off their hormone replacement therapy. So now we come full circle and realize that the Women's Health Initiative actually was such a small percentage. I mean, they really skewed the data. And to not go into it really deeply, but at the end of the day, it really was impactful to look at this data and come full circle and say, there is actually a benefit to hormone replacement therapy in all areas of a woman's body. And just thinking about, like, if it was a man taking away their testosterone, I mean, in the half of their life is lived in the
Yep.
postmenopausal phase. So we've come full circle. And so, but women don't understand is, yes, now what I have to do, and these women that come in, is their body has not seen estrogen in those particular areas in the genital urinary tract, and we have to add it back. So I'm faced with reversing the changes that have occurred for so long physiologically, these chronic progressive changes. And then I have to have a lot of conversations with these patients, like, look, this is something we need to work at now. And there's creams, there's gels, there's uh, different alternatives now that we could use. And so we've really discovered that there is a place for this treatment in other forms. We've also have some alternatives in laser therapy, which we've had for the last 8
Yes.
years, and radio frequency, that you can actually, by a mechanical way, restore the health of the vulvovaginal tissue by lasering the tissue, recruiting collagen, and helping the bloodstream, the blood vessels, the nerve endings, and restoring that genital vaginal tissue.
So
Not quite
before
as
we
it
get
was.
into that, I don't mean to interrupt you, but I want to talk a little bit more about the local therapies, like the drug therapies. How
Yeah.
long, like let's say, you're using vaginal creams, or how long does it take to reverse? Like when will they start seeing the benefit?
So usually it takes about 4 to 6 weeks to
Okay.
start seeing some benefit. And I see it very early on, depending on the patient. There is obviously, depending on how long they haven't seen it and then how long it takes, but 4 to 6 weeks, patient, I'll give them a simple cream. That's usually the least expensive as far as
Hmm.
prescription coverage. If they don't want a cream, it's messy, or they're, depending on their insurance, we'll give them like an ovule or a tablet. There's many forms. There's also some oral supplement that you can now take called Ospina, which is a SERM. It's a selective estrogen receptor modulator. So they could take it orally, and it only goes to the estrogen receptors on the vaginal mucosa. So that's really been fascinating. It doesn't affect the breast. It doesn't affect the endometrium, which is the lining of the uterus. So it could be much easier for patients who don't want to have to insert a vaginal tablet or cream or gel on a regular basis. Then we have DHEA, which is a precursor steroid of estrogen and testosterone. So that is intra rosa, and that has been FDA approved, particularly for the use of for painful intercourse. So that's an insert on an applicator that women use on a nightly basis. And so that converts to estrogen in the mucosa, which is the vaginal wall, and then it converts to testosterone in the muscularis. And so there's a lot of science with how to restructure and regenerate the vaginal tissue based on hormone supplementation. So it's really exciting. We're getting more hormones available, particularly for those symptoms.
I mean, it's about time, right? We went so many years without any research done in this area. And I recently saw an article where found estrogen receptors within the surface of the brain. And that could explain so much of the brain fog postmenopausal, perimenopausal women suffer. So I'm so glad there are
Yeah.
people like you who focus and dedicate your practices to that. So now tell me about this the invasive procedures which you are doing, and when would you do it, or what are the indications for those?
So they're minimally invasive procedures we do right in the office, and there's no pain, no downtime. And it's indicated for any woman actually that has some postmenopausal changes that is looking to seek improvement of their vaginal dryness, their painful intercourse, or sexual dysfunction, and or some urinary issues. It is basically a mechanical way to regenerate the cellular layer of the vaginal mucosa to restore the health of those vaginal cells. So you're recruiting collagen, elasticity, helping the venules with the blood flow. Blood flow is really important to the vaginal walls and the clitoris to achieve orgasm. And there is some science with radio frequency that, and they've seen the data that they can actually recruit new neurons, new nerve cells.
Hmm.
So that it's really exciting. It's basically an alternative to hormones. Number one candidate would be a woman that actually doesn't want hormone replacement therapy, has a history of breast cancer, and the estrogen word is just taboo in her mind.
Scary for
Never
them.
wants to take estrogen again. So my candidates for the laser were those breast cancer survivors. So giving them an option, finally having an option for those women who could not take estrogen. There are some women that are allergic or have a sensitivity to the cream, or don't want to have to apply something on a regular basis. So they're great candidates. Or they've been resistant to estrogen. I find there's a lot of women that, despite giving them estrogen, and remember, they haven't used estrogen for 10 years, they just don't have any response. So that 4 to 6 week period, they come back and they're like, it hasn't helped at all. And we look at their exam and we realize that they're just resistant to estrogen therapy. So I talk them through the laser option. So it is an option for everyone, but those are our patients that are particularly great candidates for the treatment.
So is it like one sitting? It's several sittings? Because I remember laser hair removal. You have to go once a month for 5 to 6 times or something like that. Is how does that work?
It's a cumulative effect. So the studies show that three treatments, 6 weeks apart, and then we like to recommend a maintenance of yearly so
Mm.
that they can continue to have the benefits of having the restoration of the vaginal tissue. But typically it's three treatments. I always say good, better, best. It's best to have the three.
So now I want to shift gears a little bit. We were talking all this time about postmenopausal women, women have been estrogen deficient. I want to shift the focus right now to stress incontinence or urinary incontinence in postpartum women, like women who've just had young women who've had one or two or three children who do their exercises with depends or all the other things, because as you said, they can't jump, they can't do anything, and they have stress incontinence whenever they lift heavy weights or lift their own kids or things like that. So how do you go about treating those patients?
Yeah, so a woman comes in and she has specifically symptoms of leakage with exercise, cough, laugh, sneeze. Stress incontinence is defined as the involuntary loss of urine due to a sudden increase in intra-abdominal pressure, which exceeds the bladder pressure. So there's not enough support underneath that bladder neck, so that
Hmm.
urethral ligament, if you will. And so these women will have, and particularly postmenopausally, have, the I say the postpartum women will have weakness in their pelvic floor. After childbearing, you've either stretched the ligaments, torn the ligaments, or even avulsed muscles in your pelvic floor. And you don't know. They're not doing MRI afterwards to see what kind of disruption or, trauma that you've had on your pelvic floor. Thank God. I, but but in general, women have a defect. They have insult to injury, and then over time in postpartum, yeah, some of those tissues can recoil, and they have improvement over time, but they have an insult to injury. So they have an underlying defect, and then over time, chronic lifting, straining to have a bowel movement, all the things that we do, all the exercise we do, all the weight bearing, and then you shift to menopause and then the depletion of hormones, which has been supporting those tissues and kind of giving them their last chance.
Hmm.
That just makes them even more weak because you lose your collagen. You lose it everywhere, in your face and in your pelvic floor. So there's a 50% increase of stress incontinence postmenopausally. But in your postpartum years, and reproductive age years, that's when that has occurred, that insult to injury. And there's a lot of women, that don't have stress incontinence, but 25 to 30% of women who have, bared a child,
Hmm.
have some form of stress urinary incontinence.
So it's funnily enough, I've never even heard this term. It was a post on, there's a physician moms
Mhm.
Facebook group, right? Which is physician mom doctors and stuff like that. And it's a massive Facebook group. And somebody had mentioned stress incontinence, and another physician from United Kingdom, UK, said, "What are you guys talking about? Don't you guys get pelvic physical therapy after your babies?" And the US people were like, "What are you talking about?" So
Yeah.
apparently, in Europe and Asia, the developed countries there, all women get 12 weeks of physical therapy, pelvic physical
Mhm.
therapy
Right.
paid by the national healthcare system. And women in the US have never even heard of that. And I was like, what? There's something called pelvic physical therapy? What is that? It's
Yeah.
beyond, I mean, clearly beyond the Kegels exercise we do, but.
Sure. And it's funny, I mentioned pelvic floor therapy to women and they look at me like I have two heads. I said there are
Exactly.
physical therapists, specifically trained to work with your pelvic floor. They have biofeedback, they work with there's skeletal muscles that you can voluntarily contract in your pelvic floor. And they are trained to help you isolate those muscles and do those Kegel exercises effectively. Because a lot of women say they're doing them and then they're sitting like this and they're not really isolating those muscles, the levator ani muscles, those muscles in the base of our pelvic floor that are holding up our pelvic organs.
Structures, yeah.
Those are the key muscles that we need to strengthen. And so the pelvic floor therapy, which we actually that's your first line therapy for stress urinary incontinence. But it's amazing to do something preventatively, and that's the problem with our medicine is we don't have the prevention is key. And so we don't have that. Like we don't have the ability. Most women won't go because A, they can't pay for it. They'd rather pay for something else. B, their doctors don't offer it. It's not universally offered. So when they come to
Yes.
me and we offer it, they're like, what are you talking about? And they're like, well, I do my Kegel exercise. I said, well, you may not be doing effectively. Let's do pelvic floor therapy. And also, too, there's not a lot of pelvic floor specialists. When I started my practice here in South Carolina, there was one pelvic floor specialist. She did it part time, and so my PA Suzanne, and I'll give her props for this. I said we need to effectively offer pelvic floor therapy. So our joke is she slept at a Holiday Inn and became a pelvic floor specialist and did physical therapy. She went and trained. We got the pelvic floor therapy equipment, Prometheus, and she started doing the pelvic floor treatment in our office because there was nobody to do it. And she effectively helped these women with biofeedback start working on their pelvic floor disorders, and it became very effective. But then we got really busy. Then finally we had some, new graduates coming out. There's more and more women now. I think we have 9 pelvic floor
Oh,
physical
wow.
therapists in the Columbia area, and they're popping up all over. It is a great for any female physical therapist out there that's training and doing their physical therapy works. If they have like a niche, like a passion, pelvic floor therapy. I mean, it is unbelievable. And there are some women that are really in our local area that are really dedicated to that treatment. And I see in the studies show greater than 50%, when these women that are, effectively doing their therapy and going home and doing the exercises that the therapist tells them to do, there's a 50% reduction in their symptoms. And so I think to be able to hold off on other treatments that, may be more invasive, I think pelvic floor therapy is really impactful and really important to help kind of kick the can down the road, if you will, and prevent having to have definitive procedures or surgical procedures.
So let me ask you this. Does the laser therapies and the RF radio frequency ablations, does it have a role in menstruating women? Like, does it help them also?
Sure. So I have a lot of women that will come in that are premenopausal, and they're looking for alternatives to their leakage. They're not ready
Mhm.
for they've done pelvic floor. Maybe they
Yes.
didn't do it effectively. We offer it. They're like, I work full time. I don't have time to do this. So I'll talk to them about radio frequency. We have Thermiva, which is a radio frequency therapy. So it's heat, very similar to the laser, and the heat drives, and the laser can do it as well, drives and delivers heat to the tissues underneath the bladder neck, and you're recreating that collagen and helping to restore that urethral ligament. So you can have, it's not as, it's not in our AUA guidelines, which is the American Urology Association, where we have lifestyle modifications, pelvic floor therapy, and then we have, mid-urethral sling, bulking agents. We have other therapies, but I think the laser can be something that may be able to give you, again, with pelvic floor therapy, a 50% reduction in your symptoms. And it depends on how severe your symptoms are. I wouldn't offer it
Absolutely.
to somebody who's wearing Depends, but I would offer it to a mom who, say, just leaks when she plays tennis or leaks when she jumps on a trampoline.
So
Yeah.
now let's move on to surgical therapies. You talked about urethral sling, etc. Can you explain how the surgical procedure works and the success rates and
Sure. So I walk my patients through sort of a spectrum of treatments, and I give them options. It's a very shared patient decision making process. The sling is our most definitive, and it's still the gold standard in the UK. Effectively, I think it was back in 19, they actually abolished the sling, and we are still offering mid-urethral sling. It is designed to basically re-support that bladder neck, that, kind of restructure that urethral ligament that was underneath the bladder neck, so you can cough, sneeze, laugh, jump, and that you have that support, if you will, so that it compresses against the pubic bone, so you don't have a leak. They're outpatient. I do them under sedation and local. There's minimal downtime. There's no external incisions. And the patient does very well. There's about a 90 to 95% success rate. So the high success rate. So if women are struggling with severe stress incontinence, and we can give them 15 to 20-year durability with that.
oh, that's pretty abolished in the UK if it's such a good procedure.
And so we have something now in the middle of the road we've had for many years. It's called urethral bulking. We started off about 20 years ago with collagen. So bovine collagen was used. It was called Contigen.
Hmm.
We injected it in and around the bladder neck. Think about the bladder neck like a tube. So you'd go inside like an inner tube, and you would inject and create these pillows. So you're narrowing the inner portion of the tube with the neck of the bladder, and effectively increasing the resistance, making it more difficult for the urine to come out. But it was very short-lived. The durability was short. It was only maybe 1 year. Other silicone polymers and other products came out on the market. Again, still very short-term. didn't get adopted by a lot of urologists or urogynecologists because short term basis that it was. It was almost like a last resort. But
Okay.
Bulkamid was developed and brought to the United States a couple of years ago, where we actually during COVID, in fact, I started using it, where we have higher durability and higher success rates. So it's a polyacrylamide gel. We call it a water gel. So it's mostly water with gel. It's almost like filler for your face or filler for
Mm-hmm.
your lips, but we put filler inside the bladder neck. And so we can see an 80 to 85% reduction in your symptoms with incontinence, a 25% dry rate, and the durability is 5 to 7 years. So for women who are postpartum or perimenopausal or just, in that 35, 45, 50 range that are, done their pelvic floor, are still having affecting their quality of life, but don't want to actually, definitively have a sling, the urethral bulking is an option.
Side effects to the urethral bulking procedure?
So we have minimal side effects. Urinary tract infection. Anytime you manipulate the bladder, we always give
Of course.
antibiotics, and decreasing the ability to empty your bladder in the first 24, 48 hours, and that's about 1 to 2%. So very
Mm.
rare. It's an in-office procedure done under local. No downtime. That's I think
Mhm.
the big thing that women of our age, we're so busy. We want to go back to work the next day, but we don't have time to take time off for a surgery. So they're going back to work or exercise or their physical activity the next day. And so, or right after their procedure. So it's nice that we have more options available for patients, and so that women understand that they're much more minimally invasive than what they heard from their mothers or their grandmothers, how they had, a bladder tack and they stayed in the hospital for 7 days. It's no longer like that anymore. And so that's where we need to educate women, to let them know we have all these options. And even sling is much more minimally invasive, and they can go back to work after 48, 72 hours.
Dr. Pazella, it's unbelievable. There's so much work down there, and honestly, we don't hear about it. Even as a female physician, I haven't heard of these procedure terms.
Mhm.
So,
Yeah, no,
can you
I mean,
imagine a layperson who's not in the medical field trying to navigate this area? It's just
I mean,
ridiculously hard.
just thinking about going to like girls' night out, for example, or recently spending some time with my friends from college, lawyers, financial business people, very highly professional women in the workforce, and they are mortified when I start talking to them about the things we're talking about today. I mean, they're just like, I didn't know anything about this. I didn't know you could
Yes.
treat it, and that's a shame, where there are educated women that I know that still don't have any education on this unfortunate intimate subject. It's sort of
Because
the
there's so much embarrassment about it, like, right? I have a friend who's a young person. She didn't even have babies, but she's a avid runner, and she was like, oh yeah, I always have stress incontinence. And I turned around and looked at her. I said, you haven't even had a single child. Why are you having stress incontinence? Have you met with a pelvic physical therapist? She's like, huh? Who? What? I'm like, and she is in the medical field. And
yeah.
again, I mean, but she was like completely a face change. I said, let's go talk about this. There are options. And I think women live in silence and they don't know who to talk to, also, right? And
Yeah.
it probably happens so far and few between. They're like, oh, I could just suck it up and live with it or something like that. So I hope when people listen to this podcast, talk about this, and men talk about this and ask their wives or sisters or aunts or whatever, hey, are you okay? I heard about this. Can there are things you can do, and take away the tabooness of all these issues. I think that's the whole purpose of this.
Yes, I mean, women will suffer in silence only because they're taking care of their children, they're taking care of their parents, they're busy. A lot of us now with our busy careers, we're focused on our
Yeah.
career. So these are all the things that I think just prevent us from trying to seek out our symptoms and seek out some help. And to really just what I say, try to regain your confidence. Women just kind of suffer and they just kind of go along with their days and deal with everybody else except themselves. Really.
I think this ties into the point of, I always tell patients, body weight has an effect on all of this, especially stress incontinence, right? Isn't the first line reduce your weight and things like that? How much of that, I mean, how much losing weight helps all of this?
I mean, it definitely depends on your weight and the loss. Weight loss in general, I tell women, will help in all aspects. You know that
Yes.
cardiovascular, preventing diabetes, preventing urinary symptoms, impact how much weight, that increase in intra-abdominal pressure, all that weight that they carry that's sitting on their pelvis. So whether it's incontinence or pelvic floor relaxation, that can certainly impact their urinary symptoms. So yes, so in all aspects, I think weight loss is so important in so many levels. And I just go over with them how important it can be. And there can be up to 50% reduction just by, that significant weight loss, but mostly weight loss, where they're carrying it. Women
Hmm.
tend to carry it in the
Belly
abdominal
region.
area
Yeah.
because of the, propensity
Pregnancies.
to the abdominal obesity with the change in hormones and our androgen effect. So, and that cortisol, bringing on that visceral fat. And so we need to decrease that visceral fat. And so that'll help with them with their pelvic floor.
So, I mean, it could also become a vicious cycle, right? You are on the heavier side. Now you're trying to embark on a healthy lifestyle. But
Mhm.
every time you try to jog or try to lift weights, you're having some leakage. And then you're like, oh, I'm not dealing with this. And you back off and then you stop exercising. And it becomes a vicious cycle. Do you intervene on them just to give them the help to go start a physical activity program?
Absolutely, because you gotta break that cycle. So if I can get them to stop leaking, so they can start exercising, and that's the other thing. The heavier they are, the harder on their joints. They have hip issues, knee issues, ankle issues. Then the orthopedic issues come along. So if we can get them to stop leaking, so they can start moving better and without leakage, then I think that that's a conversation. Like, let's
Yes.
improve your urinary incontinence so that you can go to the gym, you can take a walk. I mean, some women have not just stress incontinence, they have urge. They can't hold their bladder. So I just tell them to start walking. That American Heart Association recommends 30 minutes of some form of cardio, exercise.
Aerobic activity.
Walking
Yeah.
is what I
Mhm.
recommend, most days. And so they can walk for 30 minutes, but they say they can't get back because they're like rushing to the bathroom.
Yes.
So this
True.
is something you can
Absolutely.
treat as well. So, and then
Mm.
they limit their fluids and then they get dehydrated and then, you,
Yes.
you know what
Such.
happens there. It's just a shame. So this is where we need to educate and get them to start. And then there's some people that just don't exercise, unfortunately we have to mitigate that too. How do we get them moving? I mean, the conversations I have with women just to say, if you can just walk, and then, well, it's too hot. Well, you can go to a mall, really trying to work with them and giving them simple ways. You don't have to join a gym if you don't have the money. You can do simple things at home that you can exercise. I tell them that you don't have the money to buy weights, use cans or use,
Your
something
milk.
that you can lift like a jug of water.
Or,
Uh,
yeah.
I mean, these are things that are so important because we have muscle wasting. 50% of our muscle is lost, and we start losing muscle at the age after 30. So we have to
Yeah.
improve our muscle mass. We lose so much muscle when we're postmenopausal. So these are things that I try to get them to do simply in their own home.
It's, I mean, the barriers are insurmountable. And I think as seeing patients in different forms of life, I understand it. But the thing is, we have to prioritize it. Like, I was telling one of my friends that, I am going to prioritize waking up early and exercising because the more I put my own exercises towards the end of the day, it does not happen. And I'm not an early morning person. So, but to I have retrained myself to wake up at 4:35 in the morning just to exercise, and that's what you need to do. Like, life catches on, and you just have to prioritize your own health, because your life does depend on your health. And but we
Yes.
seem to always push it away or off to something else. Oh, we'll take care of it later. We'll catch it later, or it's not going to happen to me.
It's a
All those
lifestyle.
mentality.
It's a lifestyle change, and I tell my patients all the time, you have to change your lifestyle. And it's really hard. A lot of women have a hard time because of their family life, because of what they do. They're running around going to baseball field after baseball field, and they have to run through, and they eat Chick-fil-A, or they're just getting drive through
Just
just
to
to
make ends
eat,
meet.
manage their schedules. So it is hard, especially the women I talk to, being able to, you know, put that exercise in their regimen and try to eat healthy. I think it's a lifestyle change that I think it's very difficult. But if you can just go through the motions and give them tips and tricks on how to do that, they will adopt it.
Yes,
Being part
absolutely.
of now, we've offered the semaglutide program in our practice as well. Having these conversations with women is really opening my eyes too to how women struggle with being able to lose weight, and how postmenopausal women particularly struggle to lose weight. And even the women that say, I exercise, I eat right, I don't drink alcohol anymore, and they can't lose the weight. These are things that we need to talk about too, because they haven't changed anything, and they're just gaining weight, and that's because of the
The
impact.
body has
um,
changed.
but yep,
Yeah.
and the hormone depletion, and how important estrogen was to balance them out and keep their metabolism going, so that they didn't start packing on the weight.
Pounds.
Yeah.
We've discussed so many things. I mean, this conversation has been absolutely fantastic. But I am looking at my notes, and there's one thing I haven't asked you.
Sure.
Are there any particular treatment, or hormonal or non-hormonal, which you say, please don't do it? It's actually dangerous. Don't, there are people touting this or selling this, but this can be. Are there any such treatment options that you want the audience to be aware of and be
Sure.
aware of too?
No, so I think that there's a lot of alternatives on the market now. That you see your hyaluronic acids, for example. That's a huge market. Reverie, which is Bonafide, a company, has a product for vaginal lubrication and dryness, and offer some vaginal support as an alternative to hormone replacement therapy. So I think there's a lot of different ones out there. I think those are safe. Um, and it depends on the patient. They may or may not be effective. They may be something that you want to do kind of multimodal therapy. If you want to do laser, but then you want to maintain, you may want to add the hyaluronic acid. And what that's doing is it's promoting and building collagen. So that's been very safe. We're offering, and we have been for the last 4 years, platelet-rich plasma, which has been offered in orthopedics. You probably heard people get PRP shots
Yes.
for their joints to build
Yes.
collagen. Same thing. We're taking a woman's blood, we're spinning it down in a special centrifuge, and we're we're basically concentrating their platelets, which are rich in growth factor. So a lot of mesenchymal cells and everything is entered back into when you inject it back into the genital region. It's offering collagen support, helping with lubrication and the vasculature. So there's a lot of science that platelet-rich plasma can be utilized in
Mhm.
the genital urinary tract for stress incontinence, for vaginal dryness, for decreasing orgasm. So we have what's called the O shot, and that's quite frankly what it is. It's for orgasm.
Okay.
um,
Okay.
and results may vary. There's definitely, it's an alternative though. It's definitely something that women will reach out to me, and we obviously market it as a option for those women who are seeking not just benefits for their urinary issues and their dryness, but they may want to improve their orgasm. So,
Yeah.
they're all safe. It's your blood. It's FDA
Yeah.
cleared. It's safe. It's reproducible, and it's actually kind of fun, and we're on the forefront of of new and innovative procedures we can do for our fellow women out there that are struggling with all these
Perfect.
symptoms. Yeah.
I think the first step is to ask for help and
Yes.
be your own advocate and look for options, look for centers which
Absolutely.
are closer to home, etc. Dr. Myers was from Texas. Dr. Pezzella is in our own state, South Carolina. So there are a lot of options, and I'm sure there are other people like you in other states, or So I will put the link of your office address in the show notes page,
Thank you.
and any other ways they can reach you. Calling your office would be the best way.
They can call the office, and you can go online on our website. Also, if you want to follow us on SU Wellness Aesthetics on Instagram, Facebook, TikTok, we have some information there, and video and education as well. And so yeah, so you can comment on the Instagram posts, or call and make an appointment. Yeah, thank you.
Fantastic. All those links will be down in our show notes page. Dr. Pistala, it's been a pleasure. Thank you so much for taking time on a
Thank
weekend, may
you.
I
Yes,
add, to talk to me. So I truly
it's the only time
appreciate
we
that.
have, right?
That's true. That's the only time we have. All right.
No,
Thank
I
you so
appreciate
much.
it so much. I really do. Thank you so much for having me.